one first, and then we'll take the one you are chairing the second, sir.
Okay, by then because I sleep by about 9 o'clock.
I know.
And
so Mukesh is having some technical thing showing the slides. So
okay.
By the time we do that,
by the time, can you somehow bring my photo also somewhere?
Yeah, sir, we can see you, sir.
Oh, you can see me, but I can't see myself.
I also can't see, sir, actually.
No. He's in two images. One he is visible, in another is audible.
Oh.
Why can we run?
Go ahead with this. At least you start the
Mohit,
presentation.
can Mukesh advance the slide from here?
Yeah, he can do this. We can do this.
So Mukesh,
Yes, sir.
please present as you are doing. Okay. And
Okay,
we'll start with you and Malviya, sir. Okay.
Sir, when ready,
So,
just give the cue to the technical team to go live on the website.
yeah.
sir.
Okay. So Arpit, we can go live now. And just tell us when we are live, okay?
Go ahead, sir.
We are live?
Okay, sir. No problem. Sir, we are live now.
So good evening, everyone. Thank you for joining to this, the first of this year IRA webinar, which is called IRA eConnect. And we start today with the best clinical abstracts from the trainees from IRACON 2023, which was held at Hyderabad in November last year. I would introduce my IRA eConnect team first, led by our president, Dr. Chandrasekhara. Then I have my colleague, Dr. Damodaram, who's based at Tirupati, Dr. Arghaya Chattopadhyay, who's based in Kolkata, and Dr. Mohit Goyal, who's based in Udaipur. And I am Dr. Vinod Ravindran, current secretary of the Indian Rheumatology Association. And we are fortunate to have this very first IRA eConnect of 2024-25 being chaired by Dr. Anand Malviya. And in one word or couple of words I can say about him is that he is a living university. And we are all blessed to have you here, sir. And we have Dr. Suma Balan, head of the Department of Rheumatology at Amrita Kochi, and a pediatric rheumatologist. And then Dr. Rajendra Varaprasad, who was the scientific chair of the IRACON 2023 at Hyderabad, and our consultant rheumatology colleague from Hyderabad. And in presenters, we have Dr. Mukesh Maurya, who was trainee at that time, but now I can see from his first slide that he's an assistant professor of clinical immunology and rheumatology at KGMU, Lucknow. Then we had Dr. Jigna Bhatia, as a pediatric rheumatology trainee from Institute of Child Health at Kolkata. And we have Dr. Chandrabhushan Prasad from PGI Chandigarh. The idea behind this particular start from the best clinical abstracts from the trainee was that they undoubtedly showcase what is the best going on in our institutes in terms of research. And it was a popular demand from many of our IRA members. So without much ado, I would next invite our IRA president, Dr. Chandrasekhara, to give his welcome address. Over to you, Dr. Chandrasekhara.
Thank you, Vinod. I think I should congratulate and appreciate the efforts that was put by the entire CME team in bringing the first show. I think, of course, this is the continuation of what was a brainchild during the COVID time when we were unable to meet each other. Though COVID has come and gone, but it has taught us with some lessons and also given us some avenues through which we can connect day in and day out without spending much, of course, because any physical meeting needs a heavy investment from everyone, so including time, money, etc. But this kind of connect really keeps all of us updated and keeps going on. I think we should appreciate the efforts that when we put at that time, and also the current team to keep this at continued pace. This is the first time where we started focusing on the research and research agenda, in addition to bringing the best minds within best senior minds to chair the session, and the best young minds who have done a work on those respective areas. I hope the discussion should bring in a lot of newer ideas and newer concepts. So at this outset, I think I welcome Professor Anand Malviya and other professors and other chairs who are going, Dr. Balan and others who are going to chair the sessions. And I welcome, without much losing the time, I welcome everyone to start the sessions. Please, we go ahead with the sessions.
Thank you. So I would invite Dr. Mukesh Maurya first to give his presentation. And the chair of this particular presentation is Dr. Malviya. And after Mukesh's presentation, sir's comment, and then question and answers. Thank you. May I request everybody, apart from the speaker, to mute themselves, please. Thank you. Okay, Mukesh.
Okay. Good evening, everyone, and sorry for the inconvenience caused by my side. So I'm presenting my work on infection profile of patient and utility of neutrophil CD64 expression, preception, procalcitonin, neutrophil to lymphocyte ratio, and CRP in differentiating infections from flares and systemic lupus erythematosus. So actually, this was my thesis topic when I was in first year. So we used to have a lot of discussion boards for how to differentiate between flare and infection in patient of lupus. And so there's no a single marker that can best differentiate between the infections and the flares in patient of lupus. So I decided to do my thesis on this topic. And so about infection in lupus accounts for like 20 to 55% of death. That is a major cause of death within the first year of diagnosis due to like pulmonary infections, GI infections, urinary tract infections, and soft tissue infections. And differentiating flares from infection is a very challenging task. And there are several biomarkers that has been evaluated, but use of a single biomarker is not as sufficient to differentiate between flares and infection in patient of lupus. So the objectives of my study was to study the usefulness of neutrophil CD64 expression, preception, procalcitonin, CRP, and neutrophil to lymphocyte ratio to differentiate the infection from flares in SLE patients from a composite score. And to study the prevalence of infections in a patient of SLE in a tertiary center of northern India. So it was a observational cross-sectional study and conducted between July 21 and December 22, approximately period of one and a half year. And my sample size was 113. So we evaluate the patient on the basis of disease activity markers, SLEDAI-2K, CBC, ESR, CRP, procalcitonin, and some complement C3, C4, DSDN levels. And I have done the neutrophil CD64 expression through flow cytometry. I have used the mouse anti-human CD64 kit of BD Biosciences, and I have used a BD fax Canto second fax machine. And for preception, it was based on sandwich ELISA, and various culture was done as per the suspicion of infections, and various imaging and the bronchial lavage and was done to rule out the infections. So baseline characteristics of the patient enrolled. I have enrolled total 113 patients, of which out of 113, 107 were females and 6 patients were male. And the mean age of presentation was 28, and mean disease duration was 32 months. And the disease activity in about 28% of the patient were inactive. That's SLEDAI score less than 4 or 4 or less than 4, and 20% were in mild category, and 24% are moderate, and 27% are severe. And muscular out of 113 patients, musculoskeletal involvement was present in 77%, hematological in 75%, mucocutaneous in 71.7%, and renal in 62%, while the macrophage activation was present only in 2.7% of patients. And during that tenure, about 70.1% patient was on hydroxychloroquine, and 54% were on glucocorticoids, and 28.3% patients were on cyclophosphamide, and 9.7% on azathioprine, 8% on mycophenolate mofetil, and only 3.5% were patients on rituximab. Most common infection site of infection was urinary tract. About 53% of patients with urinary tract infections or pyelonephritis, while LRTI or pneumonia was present in 14 or 26% of patients, and a third one was soft tissue infections. And our culture results shows the growth of Klebsiella in approximately 38% patient, followed by Escherichia coli. So we divided the patient into flare group infection and the flare plus infection. So we can see that HB levels, neutrophil to lymphocyte ratios, CRP, presepsin, neutrophil CD64 expression. I have seen the MFI value, mean fluorescein intensity, that was significantly increased in infection group as compared to flare group. And while the presepsin that I have used as a marker to differentiate between infection and flare was not very much significant between the flare and the infection or a combined group. So the value of procalcitonin level was significant between the flare and the infection group, and double stranded DNA levels, SLEDAI2K, were also significant. Here I have, for further analysis, I have taken the patient only with infection and flare. I have removed both the patient with combined flare plus infection. So for further analysis, I have used the flare, one category of flare and another category of infection. So here we can see that TLC, NLR ratio, CD64 expression, procalcitonin, and anti-DSDNA values were significant between the flare and the infection group. On the ROC curve analysis, we can see that the area under curve for a TLC was 0.724, NLR was 0.778, and CRP 0.687, presepsin 0.654, and CD64 expression, MFI, mean fluorescein intensity, was 0.877, and procalcitonin 0.93. So the maximum area was under CD64 and a procalcitonin. Here we can see that procalcitonin at a cutoff value of 1.6 nanogram per ml have a sensitivity of 80% and a specificity of 87.5%. And neutrophil CD64 expression, MFI values, at a cutoff of intensity of 2458, there was sensitivity of 80.8% and a specificity of 81.2%. While neutrophil to lymphocyte ratio at cutoff 4.95 has a sensitivity of 73.1% and a specificity of 68.8%. And for TLC, at cutoff of 8800, sensitivity was 61.5% and the specificity was 81.2%. While for CRP at 10.8 milligram per liter, the sensitivity was 76% and specificity was 52%. For presepsin, at cutoff value of 67.3%, the sensitivity was 61%, approximately 60%, and the specificity was 52%. I have further for multivariable logistic regression analysis, I have created two models to avoid redundancy, consisting of first model consisting of high double stranded DNA, CD64 expression, and procalcitonin, while second model consists of SLEDI and a CD64 expression. Though for the first model, the combined of area under curve was 0.958, and for second model, the area under curve was 0.94. So on concluding, double standard DNA, SLEDI, and neutrophil CD64 mean fluorescent intensity and serum procalcitonin were found to be the most significant markers in differentiating infection from flares in SLE patients. And on multivariate analysis predictive models, the model 1 consists of neutrophil CD64 MFI values, double standard DNA, and procalcitonin, and the area of undergo was significant 0.95. And for model 2, it consists of neutrophil CD64 and SLEDI 2K, and area of undergo was 0.94. So composite biomarkers can reliably differentiate bacterial infections from flares in a SLE patients. So my limitation was the sample size was small, and it was single standard study, and the heterogeneity of the infections, and blinding was not done, so bias could not be ruled out. Thank you.
Wonderful, Mukesh. The presentation was quite crisp, clear-cut, and well described.
Thank you, sir.
When we were learning lupus, at those days, biological markers, as you have studied, were not available. The only thing we used to say that ESR does not correlate with infection. And the only thing was a CRP, if it is available in some of the laboratories, that may help in deciding whether it is infection or not. Yes, now, you are clearly now mentioning that it is CD40 neutrophil, that's right, CD40 neutrophil, right?
CD64, sir.
CD64, sorry, 40. Is it available easily? Can it be made, if I order it, is there any laboratory which is doing it commercially?
Sir, I have got through some vendor from SGPGI, so I can. I
you see, why I'm asking, your work, if it is applied to rheumatologists around India, how would they use it? They will need to have a kit for CD64 neutrophil. That's number one. And the second one, the marker is, the second important marker that you found was?
Preception, but that was not very useful in differentiating in my study, at least. That was not very useful in differentiating infection from flares.
So if you are the treating physician and a patient comes and you have all the things available, what will you be ordering to ensure that this is sepsis or it is not sepsis? Based upon your work, what will be the advice?
So one, I will order, sir, neutrophil CD64 expression, and second, sir, CRP levels, and other general markers like TLC levels. Just these three, but I will, sir, I will look for.
So neutrophil CD64 is the most important according to you.
Yes, sir.
Now, my question keeps on coming back. Can I get it done in any of the laboratories that are working in India, some of the prominent laboratories, SRL or LALS or whatever? Are they available or not?
No, sir. No, sir. I have talked to them. These are not available in their laboratories.
So your work is so important, and yet we will not be able to utilize it in our daily practice. So I think the first step should be that you can try to convince some of the bigger laboratories to make it available so that people like us who are now not in research institutions can also be, involved in this kind of work. Because we keep seeing patients with lupus, and we are just guessing whether they have infection or not. So it will, help, be of great help. And calcitonin, by the way, it didn't come out to be important according to your work.
No, sir. Procalcitonin was important, sir.
Yeah, procalcitonin.
Some significant results, sir.
What will be your advice? if I have the problem and I'm stuck, whether it is infection, it is lupus activity, besides neutrophil and 64 marker, what else can I do? CRP you have mentioned, but it is
Yes.
not very highly discriminative between the two.
Yes, sir.
Then the third will be what?
Sir, so if so, we can opt for the procalcitonin if the level is.
Procalcitonin, the sensitivity and specificity is not very high, is it?
So it was like 80%, sir, 80.5% sensitivity and 80%, sir.
So you will
Specificity.
say that procalcitonin is a good one.
Yes, sir. Yes, sir. Definitely.
So
sir.
if we combine CRP and procalcitonin for the time being till the other marker, the neutrophil 64 becomes available, we can rely on these two?
Up to some level, yes, sir. But we can rely on these markers at least, and plus clinic.
You don't sound very convincing. Why? You have some doubts?
Yeah, sometimes actually we in my study the cutoff was 1.75. Usually at that cutoff we don't we usually don't suspect infections in patients. We used to think that up to like values more than 5 nanogram per ml of procalcitonin is important, but in my study it came out to be like 1.75 nanogram per ml level is a
How do you
cutoff.
explain this? I mean, in your it is so low. Why? What happened? Why is it so low? I mean, everyone says yeah, it should be around 5 or 6. Okay.
Yes,
Any
sir.
reason for that?
No, I couldn't find, sir.
If I am allowed to explain.
Yeah, please do.
Sure, sir. I think I draw the attention to the two of the abstracts which had published in IRACON in Pondicherry, and two papers which we have published in both our IJCRA as well as in another journal, I'm not able to recollect, where we have really tried to figure out the play around between the procalcitonin, CRP, and C3 and total count with reference to 4 major diseases of our concern. SLE, rheumatoid arthritis, vasculitis, and spondyloarthropathy group.
Okay.
There's a very peculiar behavior of all these 4 components. C-reactive protein, and as all of us know, it's as such will be baseline high in rheumatoid arthritis. And any infections or anything, the CRP jumps from that base. So as a result of which, discriminating efficacy of the CRP becomes lower. But when it comes to procalcitonin, in procalcitonin, especially if there is a renal involvement, and we do know that in renal patients, especially chronic renal failure, procalcitonin is not a good marker. Even in lupus with a limited or even an early lupus disease, procalcitonin levels are marginally high. That's the reason why you got your cutoff little higher than what we see in a normal individuals. Because in normal individual recommendation is 0.25, 0.5, 0.25. Probable infection, 0.5 is definite infections, and 1 and above we think a possibility of sepsis. But in your lupus, the cutoff came was 1.75. It's correct, that's acceptable, and that's what we observed even in our population. Only way to differentiate is renal or non-renal. If there is a non-renal disease, then procal at 0.25 and 0.5 becomes the best cutoff. Even if there is a limited renal involvement, there is a possibility of procal being little on the higher side. So procal doesn't become a good differentiating point for you between them. CRP in lupus patients, there you need to use something what's called as baseline CRP when the patient was seen first without an infection. And from there, a rise should be taken as a significant point. And based on that, we have developed a model of a predicting models, I think, which we are testing internally, which will be opening it up for everyone. I think we can play around, because I think first we developed a model universal for everything. Rheumatoid, lupus, vasculitis, and spondyloarthropathy.
Chandra,
Then we realized the model has to be different for lupus, different for rheumatoid, and different for vasculitis and spondyloarthropathy. So now what the model does is, first question it asks is it lupus, rheumatoid, spondyloarthropathy, vasculitis? Then it uses 4 different pathways and 4 different scoring for each of the rise. Procal rise in lupus, it gives a lesser significance. Procal rise in rheumatoid and spondyloarthropathy, it gives a higher significance. Yes, sir.
Chandra, in lupus, what is what's your experience and your laboratory values of CRP? As far as in my lupus patients, CRP hardly ever rises,
Yes, sir.
even when they are very active.
Exactly. Lupus,
Okay.
especially other than serositis and MSK symptoms, usually CRP is never raised.
Is never.
And say, for example, what we look is if CRP is say 1 milligram per liter at the base, and you see in a visit with a fever, 1 milligram has now come to around 6 milligram or 8 milligram per liter, with no other symptoms of MSK or other
no
things.
serositis. That's the main one. No pericarditis.
Then give the importance to that CRP.
Okay.
Okay,
So,
sorry.
that's okay. No problem.
Can I take Mukesh?
Yes, sir.
Sort of, in the very sort of final stage of this, I got few comments from the delegates. Okay, can you be brief in your replies, Mukesh? So one is, will serum lactate help in sepsis in these patients? Mukesh?
Yeah. Serum, actually, I don't. Serum lactate may be higher in patients with renal involvement. So I don't know, sir. I don't
Okay.
comment. I don't.
Right. Yeah. Okay. This is not something you looked at, so I
Yes,
agree.
yes, sir.
And the one more question is that, is Procal high in DAH as well? If so, above what value would we think sepsis and not DAH? Any idea?
No, sir. Actually, I failed only one or two patient, the 113 patient of DH. So I didn't evaluate it like independently. I've seen what is the cutoff value of that DH, that value of Procal in DH, sir.
Yeah. And one final question is that, what about CD64 with regards to viral infections in SLE patients?
So it is mainly for
Because
bacterial.
the procalcitonin isn't of much value in viral infections, though quite useful in bacterial and fungal. So
Yes, sir.
CD64 has got,
So it is
yeah.
mainly for bacterial infections. So CD64 also is mainly for bacterial infections.
Okay. So I think we come to the end of this wonderful presentation. So I thank Dr. Malviya sir again and
Now I
Dr.
can see
Chandrasekhara for his.
my photo has come somehow. I don't know how.
It is
Okay,
there, sir.
thank you.
We'll send you.
No, I
And
saw myself now. Thank
yeah,
you.
yeah.
Now
Thank
my
you.
time to go to bed.
Thank you, sir. Thank you for being with us.
Thank you for
Th-
calling me. Okay,
Thank
bye-bye.
you.
I'm
Thank you,
leaving.
Mukesh. Thank you,
Good
Mukesh.
luck.
Thank you. So we move on to our next presentation. It will be by Dr. Jigna Bhatia, and the session will be chaired by Dr. Suma Balan. Over to you, Jigna, please.
So is my screen visible?
Yes, go on. Thank you.
Good evening, ma'am. Good evening to everyone. And I'd like to thank Vinod sir and the entire IRA team who give us the opportunity to present our work again. I'll start with my presentation. I will be presenting our preliminary data on predicting IVIG resistance in Kawasaki disease, a proposal for an Indian scoring system. So in IVIG, Kawasaki disease, IVIG is the mainstay of therapy. However, 10 to 20% of patients do not respond to the first dose of IVIG and continue to remain febrile. It is this subset of patients who have been seen to have a higher propensity for coronary artery lesions. The current level of coronary artery lesions is the predictor of long-term prognosis, And it is now seen that Kawasaki disease is now becoming the most common cause of acquired heart disease in children. However, Japanese scores have been mechanized to understand which subset of these patients will have IVIG resistance, and they have come up with a couple of scores. When they were applied to other ethnicities, it was known to have lower sensitivity and specificity. Even in our institute, previously we conducted a study to look at the sensitivity and specificity of these scores. And we see that all of them scores, the sensitivity and specificity was lower. So the three scores that we used were Kobayashi, Igami, and Sano. So keeping this in mind, we conducted this study with the aim and objective to produce a set of new cutoff values for IVIG resistance so that we can best predict IVIG resistance in the Indian cohort of patients and we can manage aggressively. It was an analytical study done on retrospective data collected from January 2019 to January 2022 at Institute of Child Health, Kolkata. The patients who were included as Kawasaki disease were defined as per AHA 2017 guidelines, and even IVIG resistant was defined as per the AHA 2017, which was persistent or recrudescent fever at least 36 hours after the end of the first dose of IVIG. So what we did was the Kobayashi, Igami, and Sano scores. The original framework was used to I'm sorry, I think there's some issue. I'll restart.
Yeah, reattach your file, yeah.
Ma'am, can you share your screen, ma'am?
Is it visible now?
No, Jigna, it's not visible.
Ma'am,
Your
please click
screen
on
sharing
share
has
screen.
stopped. You have to start screen sharing again. It has stopped.
I think I'll have to leave and rejoin. My Zoom window is not expanding. So can I leave and rejoin again?
Ma'am, kindly, ma'am, there is a share screen tab over there in the green, right?
The Zoom window is not expanding somehow. So I'm not even getting the.
Okay, no problem. You can leave and rejoin.
Okay, sir.
Sorry about this technical glitches.
Sir, this is not technical. Actually, there is some problem in their Zoom. So that's why I think they are not able to share the screen. So
So actually, somebody has to exit me from the thing. I'm not being able to access the Zoom panel only.
Just you restart your computer as well.
The best is you restart the system, computer. Close all the windows,
Okay.
just restart. It may take 5-10 minutes.
Okay, okay. I think.
Should we have the third presentation then while she comes?
Yeah, I think we should have the third presentation. Are you ready, Chandrabhushan?
Yes, sir.
Okay.
Should I share my screen, sir?
Yeah, please do that. And Rajendra, you would be chairing. So sorry about this technical issues. We'll take up the very last, which is in fact the very first, the best abstract awardee at IRACON 2023 by Chandrabhushan Prasad, and this will be chaired by Dr. Rajendra Vara Prasad. Over to you, Chandrabhushan and uh, Rajendra Vara Prasad. Thank you.
Thank you, sir. Thank you, sir. And I want to thank the IRACON eConnect for giving me opportunity to present my research work on this forum. I am Dr. Chandrabhushan Prasad. I am currently working in Goa as a consultant rheumatologist. So this is a paper which I want to present. It's a comparison of two dosing schedules of oral methotrexate, single dose versus split dose once weekly in a patient with active rheumatoid arthritis. It is a multi-center, open-label, parallel group, randomized control trial. By the acronym SMART. So as we all know, methotrexate is a first-line benchmark demand for RA, and it is important as a for treat to target strategy. So why it is so? Because it is very cheap, convenient dosing as a once a weekly, and it has a very long-term safety profile and also continuation rate. But however, if we methotrexate as a monotherapy is effective only in 30% of the patient achieve as a either they are in the low disease activity or in the remission. Remaining patient usually require a combination either with a conventional synthetic or biologicals. However, if we see these are the various scientific advances which we have made, but it comes with a high cost to the patient, also increase the side effect profile. So whether we can use the pharmacokinetics of methotrexate to improve the efficacy? Yes, we can by using the subcutaneous route of the methotrexate, which has showed in the studies showing a better efficacy, basically because the oral methotrexate when we take at a dose of more than 15 milligram, has there is decrease in the bioavailability almost of 25 to 30%, because they use a transport mechanism in the gut which gets saturated. So, but however, the subcutaneous route basically is not acceptable to many patients because of the needle aversion, and also the pre-filled syringes are not available in many countries. And so what about the split oral dose of methotrexate on the same day? So there is a pharmacokinetic study done somewhere in the 2006, which has showed by splitting the methotrexate on the same day increases the methotrexate serum level, the area under curve, which was almost 28%. However, there is no efficacy study or RCT on the split dose on the same dose, and also the various guidelines which are there, it was silent on this, whether splitting is help in increasing the efficacy or not. But ACR guideline has told to use split for reducing the GI side effect. So for after this thing, so that we come to a research question: does splitting the dose of oral methotrexate once weekly improve the efficacy, and how does it impact intolerance and adverse effect? So method is a 24-week pragmatic parallel group RCT. It's an open label, but our assessor is blinded. Joint assessor is the blinded. It is conducted across the 6 centers in India, and it was approved by the individual institute ethic committee, and it was registered under CTRI. So method in the form of PICOT. So participant, they are the RA patient who have fulfilled the ACR ULR 2010 criteria at the age of 18 to 60 years. Disease duration was less than or equal to 5 years. They used to be seropositive, either RF or anti-CCP. Active disease we consider as a 28 tender joint count of 4 or more, and swollen joint count 2 and more. And they should not be on demand except for low dose of prednisolone or HCQ, which was stable for at least for 1 month. And other obvious contraindication to methotrexate, those patients were excluded. Coming to intervention, basically in the first 2 weeks, both intervention control group received 15 milligram once weekly, and after on the 3rd to 4th week, they have received 20 milligram once weekly. The exact difference usually occur after the 4 week in the split dose. Usually they have received oral methotrexate 15 milligram in the morning and 10 milligram in the evening on the same day, and single dose group received just 25 milligram once a weekly on morning. This patient also receive folic acid supplementation of 5 milligram twice a week. And first 8 weeks at if their joint is very big, we can give maximum of methyl acetate 80 milligram IM or intrathecal 3. At 16 weeks of our study visit, we could add another conventional synthetic DMARD, if flavonoid or SAS, as per the assessor discretions, if DAS28 is more than or equal to 3.2. Outcome was a primary outcome was, which was assessed at 24 week, was ULR good response. Secondary outcomes were assessed at 16 and 24 weeks, was ULR good response, ULR good and moderate response, ACR 20, 50, 70, and delta change in HAC and DAS28. Our safety outcome we assess at 4, 8, 16, and 24 weeks was symptomatic adverse effect in the form of intolerance, and laboratory by seeing for transaminitis and cytopenia. Randomization was done 1:1 using online generator, and by using a block randomization, which was stratified by center, and allocation consignment done by the SNOs. So this is the briefly, this is a study design. So basically, I want to tell the first 16 week usually is the methotrexate monotherapy, because the patient was only on the method, whether in the single dose or in the split dose. At 16 week, because if some patient not in the low disease activity, so those patients were added either as per the discussion of the blinded assessor or leflunomide or SAS. So that become the combination. So statistical analysis, the sample size usually we come to 250 by assuming a ULR good response of 40 and 20% split and single dose, and considering power of study 90 and error, and then loss to follow standard 10 to 15%. That's it. Primary analysis was intention to treat, and missing data was handled using a last observation carry forward. Dichomatous efficacy outcome imputed as not response if discontinued or lost to follow. Dichotomous outcome usually analyzed by using chi-square test, and continuous outcome by student t-test. Coming to the result, the standard consort flow chart, in which 357 patient of RA was screened for eligibility, of which 104 patients were excluded. Majority was because they did not fill the joint criteria, of which 253 patients underwent randomization, 128 to split dose, and 125 to single dose. All they have received treatment. Only thing I want to tell about this, completion of treatment as per protocol occur in 88.5% in 60 week and 84.6% of patient at 24 weeks. These are the baseline characteristics which were almost comparable in both the group. Only thing they have both groups has a very high disease activity as per DAS20, ESR, and CR. Coming to the first efficacy outcome, which is the ULR good response at 24 week, it was numerically more in the split dose group. However, it was not statistically significant, and same to the others, except for the secondary outcome, which was at the 16 week. All secondary outcome at 16 week, which was actually the methotrexate monotherapy, has favored split dose over the single dose, which was statistically significant in all. Good response, ULR good and moderate response, ACR 20, 50, and 70. This is depicted in the this thing. This is same at the 24 week primary outcome. There was no this thing. And when we see at the 16 week, which usually favored split dose in all this thing. And also the DAS28, delta change in DAS28, both at 16 and 24 weeks was numerically significant in split dose group as compared to single dose group. However, delta Hag change was not statistically significant between the group at either 16 or 24 weeks. Coming to the at 16 week, how many patients were actually added a second DMARD? So by the blinded assessor, if we see the split dose group, it was 35% of the patient. But when we see the single dose group, it was almost 54%. 54.5% as percent of patients in single dose group were added, with which was almost 19.5% more in the single group as compared to the split dose group. Coming to the safety outcome, there was no death, but serious adverse effect, there were 3 in the split dose group and 1 in the single dose group, of which 2 were because of the fracture, because of the motor vehicular accident, and 2 were actually because of the method. One patient has accidentally taken methotrexate daily and came with the severe methotrexate toxicity, but managed and discharged, and we have again reinitiated her on this thing, and she has completed trial. Other patient had developed tuberculosis during the study. That patient we have to discontinue. Overall, there is no statistically significant difference in the symptomatic adverse effect or laboratory. However, they are numerically more in the split dose group as compared to the single dose group. Coming to the conclusion, efficacy-wise, primary efficacy outcome at 24 week we have not met, which we feel it is because it is a design related and our erroneous choosing the primary outcome, because almost 19.5% of patients in the single group have added another conventional synthetic DMARD that must have equalized, and we did not. But if we see the secondary efficacy outcome, which is at 16 week, which is usually the methotrexate monotherapy, with the favor split dose methotrexate is better efficacy wise, showing the ULR response almost increased by 12 to 17% and ACR 20, 50, 17 increased by 11 to 23%. Adverse effect, there was no difference, but however, there was 10 to higher persistent transaminitis in split dose and no difference in intolerance. However, they are numerically higher in the split dose group. So these are my acknowledge. I really want to thank my mentor and guide, Professor Varun, all the collaborator and the participating patients. Thank you.
Thank you, Chandrabhushan Prasad. I congratulate for an excellent study and congratulate again for your best paper award in IRACON.
Thank you. Thank you, sir.
There are many study is really appreciated because it has a lot of strengths. It has a lot of clinical impact in day-to-day practice, working on methotrexate, which is a basic molecule for treating rheumatoid arthritis, including 6 centers, and very good follow till the 88%. That is good. Everything, I think you given a clear message from your study. Though the primary outcome, which it did not fulfill, I think that has to be explored. Why, as you said, why do you think? Can you elaborate on that? Why?
So basically, when we have designed the study, that time we wanted like a pragmatic, like how the real life situation we deal with when the patient, because the maximum efficacy wise, the 4-month period is good enough that methotrexate maximum efficacy we can achieve. So when they come to if they come in the clinic, we usually tend to add another if they are not in the low disease activity or in the remission. So that's why we have planned at 16 weeks, we should add a second DMARD. But we actually, that was this thing, because that more DMARD was added in the single dose group that has at 16 weeks, that has leads to equalization. There was no statistically significant difference at the 24-week follow-up.
Okay. And as you mentioned in your introduction, the way we should have a idea about how best to use methotrexate, because it is the sheet anchor drug for management of rheumatoid arthritis, and in our at least our resource poor country where we cannot use biologics left and right. So using so previously also some these kind of studies were done.
Yeah, previously what happened, there was there was two study from India also. Sapan Pandey sir was also there, and from Pooja Dhanu. But only thing, they have used a very low dose of the methotrexate, 5 or 10 milligram, and also the splitting was over days, like after 2 days, 3 days. So that's why, but ideally, if we see the insert of the tablet and also this thing, usually they say split on the same day, and each tablet, at least gap should be 8 to 12 hours, not more than that. So basically, we want to do that, and that's why we have, and when we see for the literature, there was no study which we have found.
Yeah,
for the efficacy.
this your study is unique study, but
Yes.
I think our previous
Yes, sir.
as you mentioned, this study and one more study was there I come across.
Pooja Dhanor, and the one was from this thing. They have usually seen for the intolerance or something, sir. I don't.
And there was also there were studies where they used alternate weeks also.
Yeah,
methotrexate.
alternate weeks also, sir.
And there was one study where there were 3 groups. They gave
yes,
split.
that was Sapan Pandya, sir.
So that was
yes.
Okay.
No, the Pooja Dhanor, I think. That's why we are currently doing again this for subcutaneous and split. So those are also in this thing. So we'll in future we'll have an answer for that also.
Okay. Good.
Right.
Do we have any questions, sir?
Yeah. There's one question from the delegates. Just a clarification about your study. Both split doses were on empty stomach, is the question.
No, sir. No.
Okay.
No. We have not specifically told to take. We usually after food only, not empty stomach.
And can I the dosage 25 milligrams? How did you choose that drug? Because that is not commonly used practice. And some there is some data says the efficacy plateaus after 20 mg. As the dose increases, the efficacy may plateau.
Yeah, basically when we increase the dose, when we go more than 15 milligram oral methotrexate, there means the absorption usually, because they use a transport mechanism, reduce folate carrier, gets saturated. After that, so almost the bioavailability decreases almost to 25 to 30%. So that's why this pharmacokinetic study, which was done in 2006, so they have seen whether splitting the dose at the various point can increase the efficacy. So they have showed almost 28% increase in the area under curve of the methotrexate serum level they could achieve. So whether that has translated to the clinical efficacy, that was lacking. So that's why we have to show.
So my question is, can we do that with 15 milligrams? Like, can we do 75 twice?
So that's why
will it replicate the result?
That's why we have not this thing. We have not seen the efficacy in this thing. We have our protocols to increase till 25, and at 25 we split. When we reach that 25 milligram, we split and see. And we have not this thing because of the study visit will increase for the efficacy analysis and this thing.
Okay.
Right.
Congrats.
Thank you.
Thank you.
Thank you, Dr. Chandrabhushan Prasad. Fantastic study, and I think very relevant to our day-to-day practice, if not now, in soon enough future. And thank you, Dr. Rajendra Balaprasad, for chairing this presentation.
Thank you.
So, thank you. So we move on to the last presentation by welcoming again Jigna to start her presentation. And Suma, thank you for your patience, and over to you now. Thank you.
Yes, so Jigna will start off from where she left. So she just started the method, so.
Extremely sorry for the glitch. Just when we want the laptop to work, it just goes into rebel. So I'll be starting from the methodology. What we did is the Kobayashi, Igami, and Sano scores. We used the original skeleton and use them and try to get off new cutoffs which would be applicable to our cohort. So the entire data was split into two. The first 70 patients were the training data set from where we derived the modified versions of the score, and the next 45 patients were the testing data set on whom we had tested all the modified versions to derive the final sensitivity and the specificity. So I will go through the statistical analysis using an example. So if we have Kobayashi score, the Kobayashi score consists of these following parameters. If we take one of the parameters such as sodium, so from the data, the first 70 patients that we had, we took all the sodium values and the lowermost and the uppermost quartile was then calculated. So if 124 and 136 were the lower and the upper quartile, so whatever values were there in between 124 and 136, evenly spaced values in between those two were then taken and put in the grid. These are now called the predictive values. Similarly, it was done for the other parameters like the day of presentation, age, neutrophil percentage. Like that, we now have a grid which contains all the parameters and all the possible values it can acquire. And from this, we now bring about permutation combination and select what different possible scores it can now derive. So supposing if we say we took the baseline values, the lowermost quartiles of all the values, then there can be another combination of one from the lowermost and then next from the other. Similarly, another combination could be this. So on and so forth. Different permutation combination was done and all possible modified versions of Kobayashi scores were now derived. Similarly, the same thing was applied on Igami and the Sano score. We now have multiple modified Kobayashis, multiple modified Igami, and multiple modified Sano scores. And another score was then also derived from all the values just using simple logistic regression analysis to see which one is coming to that. And with all the modified scores, the respective allocation of IVIG resistance yes or no was also allocated. So we tested all the scores on the testing data set. And from there, whichever one was the best sensitive, had the best sensitivity and specificity was then taken into account. So there is one statistical tool that we use, which is called the K-fold cross-validation test, which was applied so that the data would have a higher accuracy and it would be trained well on the future unseen data. So this was the particular combination which had the best predictive accuracy. If I compare it with the original score, we see that the age is higher in our score, the CRP is higher, and the platelet is also high. And the sensitivity and specificity of our score sensitivity and specificity of our score, the sensitivity on both the new score and the full data is much higher than the original score. However, the specificity is comparable. The weakness of the study is that it does not take into consideration patients who had responded to IVIG in terms of fever. That means their fever had gone down after IVIG. However, they had increasing coronary dimensions after that. And it's a single center study with a smaller number of patients. And the future course would be to validate our findings across multiple parts of the country, doing a prospective multi-centric study, and also to assess if a combined score can be derived using in which we can predict those who did not respond to IVIG in terms of fever and also in terms of development of coronary artery lesions. So I can conclude by saying that the proposed score has a better sensitivity than the original score in our cohort. And if validated, it can act as a better screening guide to predict IVIG resistance and leading to aggressive management. Thank you.
That's very interesting and very nicely done study, Jigna. I must really congratulate you on, the way the study has been visioned and carried out. I realize you had a lot of fairly complex mathematical work going on there. And I noticed Debraj Pal in your authorship. So Debraj is an economist and mathematician. So that must have been a very strong boost to have in your group, actually. My question is, don't you get a lot of patients who are already treated before they come to you? And how, then does that not alter your findings? Because you may not have all the They may not have had all these blood tests done. They may not have had a sodium done, for instance, before they've come. So will that not alter your parameters?
Ma'am, if anybody comes who has already been treated, then we cannot include those patients. Only those whom we are diagnosing after admission are the ones who are included. That would become then another challenge. If we had to, then there'll be discrepancies of when the fever went down and how was the diagnosis done.
Are you continuing to use the score now?
Ma'am, we have just about started using this score.
And how is it working for you?
Just a couple of patients have come, which have not fallen into any high risk category. Since the season has just started, we just waiting to watch how it fares.
Yeah, I think what should be the next step now that you've done this much? What should be the next step?
Ma'am, we want to do it do it in a prospective manner, in a properly unified manner, so that we can have, irrespective of any particular combination, like here we just use a baseline Kobayashi, Igami, and Sano. In a proper prospective manner, if in a multicentric data, if we have, and we have all the values, all possible parameters which we can check to see how it fares, and also maybe include those who have not responded in terms of coronary artery aneurysms. Because often we might see that the fever has gone down, but then they have increasing Z scores.
Okay. Do we have any other questions from the... Can't hear you, Vinod.
Here, Priyanka. I mean, I can see him.
Yeah,
okay. Yeah. Your comments. I mean, please.
No, actually, so we have collected the data. We have come to this code. So, but we need to validate it basically. So, I think way forward is to validate it, and if we can get some more centers, then it will become more important. So that is the way forward, I think.
Right. And Damodaram, anything from your side you want to add? Damodaram, any comments?
What is the mechanism of IVIG resistance that is proposed this patient?
Sir,
It's the mechanism of IVIG resistance in these patients. Any clues?
Some genes have been, it's not really still now known how it's happening. Couple of genes have also been seen to be responsible, like the IKTP gene, but nobody really knows why it's going on.
Basically, it is severe disease. And so it's basically the whole idea of IVIG resistance scores is about predicting which children have a more severe vasculitic scores that are going to cause coronary artery aneurysms and treating them upfront in a more aggressive manner. So that we don't want to give the IVIG and then find out that they are resistant. We want to predict it upfront.
Right.
So,
okay. Any comments from you, Mohit? We will just close. Mohit? Right, you. So I think I would like to thank all the delegates who could join today, and chairpersons, Dr. Malviya, Dr. Suma, Dr. Rajendra Varaprasad, and three presenters, Jigna, Mukesh, and Chandrabhushan. Really very well done. And the IRA eConnect team, Dr. Chandrasekhara, who had to leave early, Dr. Arghya, Dr. Damodaram, and Dr. Mohit Goyal. And thank you for our technical support team, ICS. So thank you everyone once again, and good night.
Thank you.
Thank you
So much.